I am Dr.G.Abhishek Srinivas, Pediatrician and Neonatologist. Today I will be discussing about what is very commonly seen, neonatal jaundice, which is a very common condition we encounter. This is it's a yellowish discoloration of the skin, mucous membrane and the sclera. Sclera is a white of the eyes of the newborn babies. The peak incidence will be on the 3rd day to 5th day of life, and the incidence being around 70% in all the babies. The clinical features wise, there will be a yellowish discoloration of the face, forehead, and slowly it spreads to the chest, abdomen and to the arms and the feet. So the attenders, the parents have to be very vigilant about the discoloration of the baby, and as and when they have a doubt, they need to consult the concerned doctor or the pediatrician. So what is this jaundice? Like, it's a derived from a French word which is called jaune, which directly means yellow. And this is like, what are the causes of this jaundice? So jaundice wise, like the newborn babies, the liver is very premature. The metabolism and everything is very premature, and there is the RBCs which usually have a lifespan of 120 days in adults. In babies, they have a lifespan of 90 days, and there is a breakdown of this RBCs, and there is an increased production of bilirubin, and also there is a decreased clearance of this bilirubin, and this causes what we say the neonatal jaundice or neonatal hyperbilirubinemia. If you see the causes, mostly it is idiopathic, that is, the cause is not known, and other causes being the blood group difference. There is an incompatibility if the mother and the baby, that is a ABO incompatibility, and a RH incompatibility, that is a mother having a RH negative blood and a baby having a RH positive blood. The other causes coming to be like the prematurity of the baby, and if the mother has a diabetes, and if the history of birth asphyxia, and sometimes there is a inherited genetic disorders. What are these? These are like Crigler-Najjar syndrome, Dubbin-Johnson syndrome, G6PD deficiency and pyruvate kinase deficiency. This would be the inherent inborn errors in these things. And the other things will be if the mother is a thyroid, if there is a mother is a hypothyroid, is on thyroxine, the risk of the baby having the thyroid is manifold. And if the previous sibling, that is the first baby who had undergone a neonatal jaundice, then the next baby's risk is threefold. So how do you diagnose this? Once there is clinical icterus, that is a yellowish discoloration, now there is a non-invasive method that is called transcutaneous bilirubin, that is checked with a handheld sensor, and then if the value comes high, then for the accurate values we check for the blood test. The blood test being a total serum bilirubin, where there are two components, there is a direct component and the indirect component. The total serum bilirubin give an accurate value about the bilirubin. Once the value, we check it with a normal normograms, where we plot the weight of the baby against the hours of the baby's life, and then if it is high for that value, then we start upon the treatment. So the treatment would be like, it will be based on the cause. Like if for example it's because of some milk, like there's some dehydration going on, we suggest that the baby may be given more amount of breastfeeds and formula, so the hydration status improves. And that doesn't help, the next would be the hospital admission, where we say the phototherapy, where the baby is kept under special blue lights, where the baby is undressed, only the diaper is kept and a special mask for the eyes is kept, and baby is continued on the phototherapy for 24 hours, and the levels are rechecked. If the values come high, then we go for a higher where we start on a double surface, and if doesn't subside, we go for a triple surface, where it's called the intensive phototherapy. And this doesn't help if there is a history of this incompatibility, that is the RH incompatibility or the ABO incompatibility. What we say, the IV immunoglobulins, that those have a role, where we give a IV immunoglobulin. And if this doesn't help the baby, and if the bilirubin is on a higher range, then there are a risk for complications, and the complications are devastating, where there is like what we call the BIND, that is bilirubin induced neurological dysfunction, previously known as kernicterus, where there is irreversible damage to the brain, that is the values of 25 or 30 when the bilirubin reaches, there is irreversible damage and there is accumulation of the bilirubin in the brain leading to deafness and a long-term neurological sequelae where there is a cerebral palsy and hypotonia. So this has to be prevented at any cost, and for this now the latest this thing would be the exchange transfusion, where there is a double volume exchange transfusion. In this procedure, we change the blood of the baby, the whole of the blood, with a new blood, that is donor blood with a double volume with a push-pull method, and the whole of the blood is cleansed and a new blood is put into the baby, and this is very life-saving and prevents from all the devastating complications.